It is January 20th, 2026. The holidays are definitely a distant memory. The coffee is brewing. And if you are a postgraduate student in anesthesiology, specifically if you're gearing up for the MD exams, maybe at Gujarat University or, anywhere else facing the heat right now, the panic is probably starting to feel very real. You've got Miller on one side, Morgan and Pyle on the other, and this stack of clinical notes that looks a bit like the Leaning Tower of Pisa.
That's the absolute reality for every resident this time of year. And look, that's exactly why we are doing this today.
Right.
We aren't just exploring a topic for curiosity's sake. Today, we are shifting gears. This is full-on exam mode.
And we are tackling what I always think of as the holy trinity of neuroanesthesia: stroke, intracranial aneurysms, and of course, carotid endarterectomy.
These three are the cornerstones. I mean, without a doubt. You walk into a theory exam, you will see a 20-mark long answer question. Something like, manage a patient with a subarachnoid hemorrhage.
And in the Viva.
In the Viva, you're going to get grilled on the pathophysiology of ischemia. So my role today, it isn't just to be the expert guide. I'm putting on my senior faculty hat.
The examiner's hat.
Exactly. We're going to take that massive volume of reading Miller, Harrison's The ICU book, and we're going to structure it. Structure it so you don't just pass, but so you score those, those distinction marks.
Okay, I'm ready. I'm picturing myself as the tired resident, pen in hand. Let's start with Part A, stroke. It's a huge topic. Where do we even begin for an exam answer?
You start with framing and definitions. Always. Do not just dive into drugs and management.
Okay.
The standard texts, Harrison's and Morgan and Mikhail, they're very clear on this. You absolutely must distinguish a stroke from a TIA, a transient ischemic attack.
And the classic teaching is the 24-hour cutoff, right?
Historically, yes, that was the line. A stroke was a neurologic deficit lasting more than 24 hours, caused by infarction. A TIA resolved within 24 hours, usually in less than an hour, actually.
But there's a catch.
There is. And this is the nuance that gets you the extra points. It's the tissue definition now. A TIA is defined by the absence of acute infarction on imaging.
So even if the symptoms lasted 10 minutes?
If there's dead tissue on the MRI, it's a stroke, period. You should think of a TIA as the angina of the brain.
That's a great analogy. It's the warning shot.
Exactly. And for us, for the anesthetist, this matters because of the sheer burden of the disease. Stroke is the third leading cause of death and a major cause of long-term disability.
We see it everywhere.
In the ICU, we manage the acute phase. In the OR, we manage the risk. So when you're writing your introduction, you define it, and then you mention that stroke is a heterogeneous disease. It's not one single thing. It's a vascular event with huge systemic consequences.
Okay, so we've defined it. Now, classification. I feel like this is a place where you can get bogged down in detail. What's the highest yield way to break this down on paper?
Keep it simple. You classify by mechanism. 85% of the time, it's an ischemic stroke. And the other 15%, it's a hemorrhagic stroke.
So let's unpack ischemic first.
Ischemic strokes are either thrombotic or embolic. Thrombotic is basically a heart attack in the brain. You have atherosclerosis, plaque rupture, local clot formation.
Just like an MI?
The same pathophysiology. This usually happens in the large vessels, the carotid, the middle cerebral artery, or it can happen in the tiny vessels. We call those Lacanier strokes.
And embolic means the clot. It came from somewhere else.
Correct. It traveled from a proximal source. And usually that source is the heart. Think atrial fibrillation, valvular disease, or maybe a mural thrombus after a big MI.
Or from the carotids themselves?
Yes, artery-to-artery embolism. A piece of plaque breaks off and flies upstream. This distinction is really important because the treatment to prevent recurrence is totally different.
Okay, and then we have the other side of the coin, the hemorrhagic strokes.
Right, and that's what's into two main types. You have intracerebral hemorrhage, or ICH, and you have subarachnoid hemorrhage, SAH.
ICH is the hypertensive one.
Usually, yes. It's the rupture of small penetrating vessels deep in the brain parenchyma caused by chronic high blood pressure. And if you want to drop a name to impress the examiner,
I do.
Mention the Charcot-Bouchard aneurysms. These are microscopic aneurysms in those tiny vessels that just boost under pressure.
And SAH, that's usually the ruptured berry aneurysm. That feels like a whole beast of its own, which I guess we'll get to in Part B.
It is, and we will. But before we move on, there's one concept in stroke pathophysiology that you absolutely must understand. I mean, if you get a short note on pathophysiology of ischemia, this is your entire answer.
Okay.
The concept of the penumbra.
The penumbra. This is the time is brain idea.
Precisely. Imagine a bullseye. The dead center of that bullseye is the ischemic core. Blood flow there is critically low or even zero. maybe less than 10 to 12 milliliters per 100 gram per minute.
And those cells are gone.
They're gone. They undergo irreversible necrosis very, very quickly.
Okay.
The sodium-potassium pumps fail, calcium floods into the cell, you get cytotoxic edema, and the cell dies. It's over.
But the ring around that bullseye.
That is the penumbra. Now, this tissue is functionally silent. The patient is paralyzed or can't speak, but the tissue itself is structurally intact. It is alive.
Just barely.
Barely. It's idling. It's surviving on fumes, really, thanks to collateral circulation, often from the circle of Willis or smaller leptomeningeal collaterals.
But it's on the edge. It's unstable.
Incredibly unstable.
Mm.
If you don't restore blood flow, the cord just expands and eats the penumbra. That is why we rush for thrombolysis or thrombectomy. And for us as anesthetists, this is absolutely critical because our hemodynamic management determines if that penumbra lives or dies.
Because it's lost its autoregulation.
Exactly. Its blood flow is entirely pressure passive. It completely depends on your MAP.
Okay, I want to touch on clinical features briefly. We all know the FAST acronym: face, arm, speech, time. But let's talk imaging. In an exam, how do I describe the role of a CT scan versus an MRI?
You start by saying that a non-contrast CT is the gold standard for the initial assessment, but you have to clarify why.
It's not to see the stroke.
It's not. It's to rule out the bleed. Blood shows up immediately as bright white hyperdense. An ischemic stroke, on the other hand, might be completely invisible in the first few hours, or it might show really subtle signs like the dense vessel sign or a loss of gray-white differentiation.
An MRI.
MRI, specifically diffusion-weighted imaging or DWI, is far more sensitive for early ischemia. It can show the infarct within minutes. But in the real world, in the acute setting, speed is everything, so CT usually wins out.
Okay, so let's talk about that management. Perioperative considerations. Let's say I have a patient with an acute stroke, or I'm managing one in the ICU. The biggest area of debate, it always seems to be blood pressure.
It is the single biggest dilemma. Most of these patients present with significant hypertension, and the knee-jerk reaction for a junior resident is to lower it. Oh, the BP is 180, let's give some labetalol.
Which is a mistake.
It can be a catastrophic mistake. Do not treat it aggressively.
You'll kill the penumbra.
You'll kill the penumbra. In that stroke area, autoregulation is gone. Flow is passive. It relies entirely on the mean arterial pressure, the MAP, to push blood through those tiny collateral vessels. If you drop the MAP, you starve the penumbra. It's that simple.
So we actually let them run high.
We practice what's called permissive hypertension. The guideline like a systolic over 220 or a diastolic over 120.
Is there an exception?
Yes. The big exception is if they're a candidate for thrombolysis. In that case, we need the pressure under 180/50/110 to reduce the risk of bleeding into the brain. But generally speaking, high is better than low. And if you're inducing anesthesia, hypotension is your absolute enemy.
Okay, what about the other pillars of management? Ventilation?
Well, avoid hypoxia, obviously, that's a given. But the trap here, and examiners love to catch students on this, is CO2.
You're not supposed to hyperventilate.
Do not hyperventilate an ischemic stroke patient.
Because hypocapnia causes vasoconstriction.
Correct. We use hyperventilation as a last-ditch rescue maneuver to lower intracranial pressure in a patient who is actively herniating. But in pure ischemia, vasoconstriction just steals blood away from the brain. It makes everything worse. Your goal is normocarbia. PaPO2 around 35 to 40 mmHg.
And glucose.
So important. Hyperglycemia, it drives anaerobic metabolism. When the brain is ischemic, it switches to glycolysis. If there's too much sugar floating around, it produces excessive lactate.
Lactic acidosis.
Lactic acidosis in the brain tissue, which is incredibly neurotoxic. So you want to keep the glucose under 180 mg/dL. But obviously, you have to avoid hypoglycemia like the plague because the brain has no glucose reserves at all.
What about temperature?
Treat fever aggressively. Hyperthermia cranks up the cerebral metabolic rate of oxygen, the CMRO2. If your oxygen supply is already compromised, the last thing you can afford is to increase the demand. Every degree of fever worsens the outcome. Paracetamol, cooling blankets, whatever it takes.
Okay, one last practical point on stroke before we switch gears. Timing of elective surgery. A patient had a stroke 3 weeks ago. Now they need a hip replacement. How long do we wait?
The exam answer, and this is straight from Miller, is to delay elective surgery for at least 3 to 6 months.
Why so long?
The risk of a recurrent stroke is highest in that first month. It's incredibly high. After about 6 months, the risk plateaus, although, it does remain higher than in the general population forever. But if surgery is urgent, you have to weigh the risks. For elective cases, you wait.
Got it. Okay, that feels like a really solid structure for a long answer on stroke. Let's move to part B, intracranial aneurysms. This feels, I don't know, higher stakes. We're talking neurosurgery now.
It is. And for the exam, you need to start with definitions and anatomy again. An intracranial aneurysm is just an abnormal dilation of an artery. The most common type by far is the saccular or berry aneurysm.
And they love to hide in very specific spots, don't they?
They do. The circle of Willis. Specifically in the anterior circulation.
Mhm.
The junction of the anterior communicating artery, the ACOM, is the #1 spot.
And after.
Then the posterior communicating artery, the PCOM, and the bifurcation of the middle cerebral artery, the MCA. Those are the big three.
And if one of these ruptures, we are dealing with a subarachnoid hemorrhage, SAH, the classic thunderclap headache.
The worst headache of my life. That is the phrase you have to use. When that rupture happens, it's a complete physiologic catastrophe. Arterial blood just blasts into the subarachnoid space.
And the ICP skyrockets.
Instantly. It can go as high as the mean arterial pressure.
Which, I guess, stops the bleeding, a tamponade effect.
It is a tamponade effect, yes.
Yeah.
But it also stops cerebral perfusion. Remember, cerebral perfusion pressure, CPP, is NAP minus ICP. If ICP equals MAP, your CPP is 0.
Which is why they lose consciousness.
Exactly. That's why the patient often loses consciousness right at the onset. It's a global ischemic event.
So if they survive that initial blast, what are the big complications we're watching for in the ICU?
There are 3 big ones you must list in your answer. Number 1, rebleeding. That little clot that formed over the rupture is incredibly unstable. The risk is highest in the first 24 to 48 hours.
Okay, number 2.
Number 2 is vasospasm. This is a delayed ischemia, and it usually peaks around day 4 to day 14. After the bleed, it's a huge cause of secondary injury.
And 3.
And number 3 is hydrocephalus, because all that blood in the CSF pathways clogs up the drainage system.
Let's jump to the preoperative evaluation. We have to grade these patients, right?
Yes, you absolutely must mention the grading scales. The Hunt-Hess scale is the classic one. Grade 1 is a patient who is asymptomatic or just has a mild headache. Grade 5 is a patient in a deep coma. It's a powerful predictor of mortality.
And there's another one based on GCS.
The WFNS scale, the World Federation of Neurological Surgeons scale, it relies heavily on the Glasgow coma scale.
I've also read about the cardiac effects, this neurogenic stun myocardium.
Yes, you should mention that. The SAH causes a massive, and I mean massive, catecholamine surge. You can get ECG changes that look exactly like a heart attack, ST elevation, T-wave inversion, or prolonged QT interval.
So how do you tell the difference?
You need to check troponins and get an echo. Often the echo will show wall motion abnormalities that don't fit a specific coronary distribution. It's crucial because these patients are hemodynamically very, very fragile.
Now, let's get to the very high-yield section, anesthetic goals for aneurysm surgery. This feels like where the money is.
If you remember one formula from this whole discussion, make it this one. Transmural pressure, or TMP, equals MAP minus ICP.
Okay, let's unpack that. Transmural pressure is the stress on the wall of the aneurysm itself.
Exactly. It's a pressure pushing out from inside the vessel, which is the MAP, minus the pressure pushing in from outside the vessel, which is the ICP. And your whole job is a balancing act.
A balancing act? How so?
Well, if the TMP is too high, let's say you spike the blood pressure during laryngoscopy, or you drop the ICP too fast by draining CSF, the aneurysm ruptures.
But if the TMP is too low,
then the brain doesn't get perfused, and you cause ischemia. So the goal is a tight brain, relaxed aneurysm. You want to avoid acute hypertension, especially during intubation. No coughing, no bucking, but you have to maintain enough pressure to perfuse the brain.
And you also need to give the surgeon access.
Right. You need to facilitate surgical exposure by relaxing the brain, usually with mannitol or some mild hyperventilation.
So talk to me about induction. The goal is smooth as silk, as smooth as you can possibly make it. You have to blunt that sympathetic response to laryngoscopy. We use things like lidocaine, about 1.5 millikilogram, fentanyl, maybe 2-3 millikilogram, or even esmolol or remifentanil infusion.
And for the induction agent itself?
Propofol or thiopentone are your best bets. They both lower CMRO2 and ICP, which is exactly what you want.
What about ketamine?
For the exam, you say you avoid ketamine. Traditionally, it's thought to increase cerebral blood flow and ICP. Now, in modern practice, that's a bit more debated, but for a classic exam answer, sticking to propofol is much safer.
And muscle relaxants. Rocuronium or vecuronium are standard. You You want to avoid succinylcholine if you can, because of the theoretical, though probably small, rise in ICP from fasciculations.
And for maintenance.
You want a slack brain, so the surgeon can gently retract it without causing damage. Many people prefer Tyva total intravenous anesthesia. If you use volatiles, keep them under 1 mmHg because they are cerebral vasodilators and can raise ICP.
Which you can offset with some hyperventilation.
You can, but you have to be so careful not to overdo it and cause ischemia. It's a fine line.
Okay, the nightmare scenario. The aneurysm ruptures intraoperatively, the surgeon is dissecting, and suddenly a field full of red. What do we do?
You have to act instantly. Your goal is to drop the transmural pressure to 0, or as close as you can get, to allow the surgeon to see and clip the bleeder.
How do you do that?
You can use adenosine to induce temporary cardiac arrest, just for a few seconds. It gives the surgeon a bloodless field to work in. Or you can use rapid-acting vasodilators, like nitroprusside. You might also ask your assistant to compress the carotids in the neck. The second that clip is on, you restore the BP and volume immediately.
That is incredibly intense. Let's assume the surgery goes well. Post-op, our biggest enemy is vasospasm. How do we manage that?
Well, the old teaching, the classic answer, was Triple H therapy: hypertension, hypervolemia, and hemodilution.
Is that still the standard of care?
It's been updated. We've moved away from it. Now we focus mostly on induced hypertension and euvolemia. The problem with Triple H was that we were fluid overloading patients into pulmonary edema.
And we use a specific drug.
Nimodipine. It's a calcium channel blocker, and it's standard of care.
Does it actually stop the spasm, though?
That's the interesting thing. If you look at the data in Miller, it doesn't actually reverse the vessel spasm much on an angiogram, but it improves outcomes significantly.
So it's neuroprotective.
It seems to be neuroprotective in other ways, perhaps by preventing that toxic calcium influx into injured neurons. The standard dose is 60 milligrams every 4 hours for 21 days.
Okay, and electrolyte disturbances. You mentioned hyponatremia. This feels like a trap.
It is a classic exam trap. You have to be able to distinguish between SIADH, the syndrome of inappropriate ADH, and cerebral salt wasting syndrome, or CSWS. They both present with low sodium.
What's the quick exam tip for telling them apart?
Volume status. That's the key. A patient with SIADH is euvolemic or even hypervolemic. They're holding on to too much water.
And cerebral salt wasting.
The patient with CSWS is hypovolemic. They are dehydrated because their kidneys are just dumping salt and water. You treat SIADH with fluid restriction. You treat CSWS with salt and fluids.
And if you restrict fluids in a salt waster,
you will cause an infarct. Vasospasm loves hypovolemia. So a careful assessment of volume status, looking at CVP, mucous membranes, urine output, is absolutely critical before you treat that sodium level.
That's a huge point. Okay, we've covered the bleed. Now let's move to Part C, Carotid Endarterectomy, CEA. This is about preventing the stroke in the first place.
Exactly. This surgery is all about removing that atherosclerotic plaque from the carotid bifurcation. The indication is usually a symptomatic stenosis of more than 70%. Or maybe an asymptomatic stenosis of more than 60%.
And the biggest topic here, the great debate, is the anesthetic technique. General anesthesia versus regional.
Examiners absolutely love this question. You need to be able to argue both sides fluently.
Okay, let's start with the case for general anesthesia.
GA is comfortable for the patient. You have a definitive, secure airway, which is great when the surgeon's working in the neck. You can tightly control CO2 and thus cerebral blood volume. And the volatile agents provide some degree of metabolic depression. They decrease CMRO2, which is theoretically neuroprotective.
Okay, and the case for regional, this is usually a cervical plexus block, right?
Correct. It can be a deep or a superficial cervical plexus block.
Mm-hmm.
And the one massive advantage of regional is that the patient is the monitor.
Oh, wait, this...
Awake testing. If you clamp the carotid artery and the patient stops squeezing a squeaky toy or can't answer a question, you know instantly that they have cerebral ischemia. It completely eliminates the need for complex, expensive monitoring like an EEG.
So, is there a winner? What does the evidence say?
You must quote the JA trial.
JA.
The JA trial was huge, and it showed no significant difference in the rates of stroke or death between general and regional anesthesia for CEA. So the safe exam answer is that the choice depends on surgeon and anesthetist preference and patient factors.
But you'd still emphasize the monitoring advantage of RA.
You would. You'd say that while outcomes are similar, RA allows for the most sensitive and specific monitoring of cerebral ischemia.
Okay, so regardless of the technique, what are our main anesthetic goals?
Stability. Number one is hemodynamic stability. The carotid sinus baroreceptor is right there in the surgical field. Any manipulation can cause severe bradycardia or hypotension.
So you have to be ready.
You need to be ready with atropine or glycopyrrolate. You might even ask the surgeon to infiltrate some local anesthetic into the carotid sinus to block that reflex arc.
And during the clamping phase, what's the goal then?
This is the most critical moment. When the surgeon clamps the carotid, blood flow to that side of the brain depends entirely on the collateral flow through the circle of Willis. So we usually deliberately drive the blood pressure up.
Permissive hypertension again.
A bit, yes.
Yeah.
We want the MAP slightly high, maybe 20% above the patient's baseline, to help push blood across that circle.
And conversely, when they take the clamp off,
We run the pressure down. We need to prevent something called hyperperfusion syndrome.
Mm-hmm.
So you have to be very agile with your vasoactive drugs, phenylephrine or noradrenaline, to raise the pressure, and then maybe nitroglycerin or labetalol to lower it.
Let's talk about monitoring. If the patient is asleep under GA, how do we know if the brain is happy during that clamp time?
Right, since we can't ask them to squeeze a hand, we have to use surrogates. An EEG is common. You're looking for slowing of the waves or a loss of amplitude on the operative side.
What else?
SSFP's somatosensory, evoked potentials. TCD, transcranial Doppler, to look at the flow velocity in the middle cerebral artery. Or, the old school method, you measure the stump pressure.
Stump pressure? What's that?
The surgeon puts a needle in the carotid artery distal to the clamp and hooks it up to a transducer. It measures the back pressure coming through the collateral circulation.
And there's a magic number.
The classic exam number is 50 mmHg. If the stump pressure is less than 50, it implies that the collateral flow is inadequate, and the surgeon will typically place a shunt.
A shunt is basically a bypass tube.
Yes, it's a little plastic tube that bypasses the clamped segment to keep blood flowing to the brain. But shunts have their own risks. They can dislodge plaque and cause the very stroke you're trying to prevent, or they can dissect the vessel. So we only use them if the monitoring shows clear evidence of ischemia.
And intraoperative management always involves heparin, doesn't it?
Yes. We heparinize before the clamp goes on to prevent clotting in the stagnant vessel, usually about 5,000 units or 100 units per kilo. And we do not always reverse it with protamine at the end.
Why not?
To prevent thrombotic complications on that fresh, raw endarterectomy site, unless there's major surgical bleeding, we often let it wear off.
Okay. Post-operative complications. You mentioned hyperperfusion syndrome.
Yes. This can happen because the vascular bed distal to that tight stenosis has been chronically dilated for years. It was starved for blood.
Yeah.
Suddenly, you open the floodgates with the surgery.
And the vessels can't constrict.
They've lost their autoregulation. This can lead to massive cerebral edema, a severe unilateral headache, and potentially even a hemorrhage. It's why strict BP control post-op, keeping the systolic below 140 usually, is absolutely non-negotiable.
And the other scary one, the airway one, hematoma.
A neck hematoma after a CEA is a life-threatening airway emergency. It compresses the trachea, but also the venous drainage from the head.
And what's the protocol?
Do not wait. Do not try to intubate. If the patient is struggling to breathe and has a tense, expanding hematoma, you scoop the neck.
You mean open the wound?
Open the wounds.
Right.
Immediately at the bedside. Release the pressure. Take out the sutures or staples, let the blood out, and then secure the airway. If you try to intubate a patient with a closed, tense hematoma, you will likely fail and lose them. This is a favorite what you do now scenario in oral boards.
That is a critical life-saving tip. And what about cranial nerve injuries?
They're common, usually from traction. You can get a hypoglossal nerve injury. The tongue will deviate towards the operative side. A vagus nerve injury can cause hoarseness from the recurrent laryngeal nerve, or a marginal mandibular nerve injury, which causes a drooping lip.
And you just assess for those in recovery.
Exactly. Stick out your tongue, say, "ee, give me a big smile."
We have covered a huge amount of ground. Before we wrap up, let's do a quick Viva Traps section. Where do students usually trip up on these topics?
Okay, trap number 1. Hyperventilation in ischemic stroke. I'll say it again, don't do it. It worsens ischemia.
Trap number 2.
Fluid choice. Do not use dextrose-containing fluids. The brain does not handle hyperglycemia well during stress. Use normal saline or another isotonic crystalloid like plasmolite.
Trap 3.
Confusing CSWS and SIADH. Remember? Look at the volume status. If the patient is dry, salt wasting. Give salt.
And a last one.
Forgetting to mention the cardiac evaluation in a CEA patient, you must remember that atherosclerosis is a systemic disease. If they have plaque in their carotids, they have it in their coronaries. You have to treat them like a cardiac patient.
And a quick tip on diagrams?
Yeah.
You said they're key for the long answer.
Yes. If you're writing about stroke, draw the penumbra, a simple circle inside a circle. Label the core, the penumbra and show some collateral vessels. For aneurysms, draw the circle of Willis and put a little bubble at the ACOM or PCOM.
And for CEA?
A simple flowchart. Awake versus asleep. This leads to what kind of monitoring, and that monitoring leads to the shunt decision. It breaks at the wall of text and shows the examiner you understand the logic.
Fantastic. So, to summarize the whole mission of this deep dive, the take-home points.
The take-home message for the exam is structure. For stroke, it's all about saving the penumbra. Time is brain, and careful BP control is key.
For aneurysms?
It's all about transmural pressure. Your goals are to prevent rupture before clipping and prevent vasospasm after.
And for CEA?
It's all about maintaining collateral flow during the clamp. That means good hemodynamics and being ready to shunt if needed.
This has been an incredibly high-yield session. I honestly feel like I've just done a week's worth of reading in under an hour.
Well, that's the goal. To all the candidates at Gujarat University and everywhere else listening, you know this stuff. Now you just need to present it with confidence and structure. Good luck.
You've got this. Thanks for listening to The Deep Dive. We will see you on the other side of the exams.